So I would like to welcome you to this second joint seminar between ECDC and ESPID. We are very happy that we managed to do it. We wish you Happy New Year, even though it's already, January is almost gone. 2022 started in a difficult way for many countries, but nevertheless, we are focusing in this seminar in the one of the major complications of COVID-19 in children, MIS-C. I would like to welcome all our speakers and thank them for accepting our invitation to present. And I think we're going to have a very interesting discussion and an overview of what is going on in Europe. I would like to ask Delane to say a few words, and then we can start with the presentations. Just before finishing, I'd like to let you know that we are recording this seminar because this webinar for both for taking minutes and writing a report, but we're also aiming, like the first one, to put it up on our website and with a link from the ESPID website also. Thank you. And also, this goes also for the speakers. If anyone has any problem with that, please let us know. Please, Delane.
Yeah, thank you very much. And this is the second webinar with ECDC and ESPID. I think it's been a really great collaboration between our two societies. And I think ESPID have valued the collaboration with ECDC. This webinar is on MIS-C or PIMS-TS, whatever you want to call it. But I think this will be a really important opportunity. In the second session, we will have a discussion about case definitions, which I think will be important for us across Europe to be working on some collaborative aspects. So thank you all for attending and for the ECDC for involving ESPID in this collaborative work. Thank you.
Thank you. So our first speaker is Dr. Broden from nearby, actually, Stockholm. Please, would you like to say a few words about yourself and then...
Sure. Thank you. Thanks for inviting me. So I am a pediatrician and a pediatric immunologist, professor of pediatric immunology. I've been working at the Karolinska Institute for a number of years, but currently I'm in transition and have joined recently Imperial College London as chair and professor of pediatric immunology there. But I will talk, as I am more of an experimental immunologist and pediatrician than an epidemiologist, I will talk more about the immunology of MIS-C as we have studied it, and say a few words only about the Swedish sort of numbers and so on. So if you go to the next slide. So Sweden has, as you know, had open schools more or less throughout, with some distance learning only in the older kids. Sports activities and other activities for children have been prioritized and have been ongoing throughout the pandemic, which differs from many other countries, as you all know. And so with that in mind, there's obviously been a quite large spread of SARS-CoV-2 in Sweden, and there has been 306 cases of MIS-C. 70 of these have required ICU, and none of them have died, fortunately. And so I think, this has been spread out throughout the country. And I will not say anything more about sort of the numbers in Sweden, so you can move on to the next one. But what I would like to talk a little bit about is what we have learned around the immunology of MIS-C and COVID-19 in children. So next one. As you all probably, or many of you are aware probably, children predominantly have a mild acute COVID-19 unless some severe underlying condition, immunodeficiency, or severe heart or lung disorders. But and why this is, why children manage to clear this virus or at least prevent severe disease, has been subject of much studies. And the main sort of knowledge highlighted in these slides from a number of investigators, including us, has been that there is a primed antiviral immune response in the mucosa of the nose and the mouth in children that differs from adults. And the idea has been that this rapid response to the viral infection helps children to clear the virus, or at least fight off the virus rapidly without requiring a significant systemic inflammatory response or severe disease, and without risking pneumonia in the same way that adults would. Next slide. But what's puzzling then is that this other condition, which is the focus of today's discussion, MIS-C or PIMS, is predominantly occurring in children and young people. So this kind of opens a sort of puzzling conundrum there, that why mild acute infection and then MIS-C? Is there a link between the two? So that's what I wanted to spend some time talking about today. And so we decided, once this cases of MIS-C became apparent in the spring of 2020, to study their immune system using the technologies that we had in-house. We collaborated with colleagues in Italy at Bambino Gesù in Rome, and we managed to get samples from the first few cases and compare them to children with Kawasaki disease that were collected years prior, given the clinical overlap in some of these cases. We also compared their immune response to children with mild acute COVID-19 and healthy children. Next slide. And what we found in this work was that clearly MIS-C is a hyperinflammatory syndrome. They have strong inflammatory responses, as you all know. And these responses clearly differ from Kawasaki disease. They're very sort of distinct. They also differ from severe acute COVID-19, and in this case was adults, but I think subsequently we've learned that they also differ from acute severe COVID-19 in children. The next slide. And when it comes to pathology, the only thing we were able to find was a sort of diffuse, very broadly reactive autoantibody profile, with autoantibodies targeting a number of different proteins that differed between patients, but were clearly more pronounced than what we would see in cases of healthy children or mild co-virus 2 infection. And some of the target proteins, such as these casein kinases, also differed from Kawasaki disease. But at the same time, multiple groups have now reported autoantibody profiles, and it's pretty clear that MIS-C patients have broadly reactive autoantibodies. But it's not that one specific target is the focus of all of these conditions that would explain the pathogenesis. So it's more that they produce autoantibodies, but probably against a wide variety of different targets. So next slide. And this has led to another sort of development, predominantly driven by this finding by Moshe Arditi's lab at UCLA and colleagues in the US, showing that in the SARS-CoV-2 receptor binding domain, there is an S1 motif that acts as a superantigen and can trigger non-specific T-cell activation, specifically of T-cells carrying a particular beta chain, TRBV11.2. And this has been reported now by 5 or 6 different groups, seems to be a very reproducible pattern. But the question then becomes, okay, if there's unspecific T-cell activation by a superantigenic motif, number one, why does it happen a month to 2 months after the initial infection? That's quite different from other superantigen-mediated diseases. And why only in a small number of children? That's also quite puzzling. Next slide. So one of the suggested sort of explanations for this is that maybe the focus of the superantigen and the location of the superantigen is key. We know that in acute COVID-19 in children, there's often a focus of intestinal symptoms that might slightly differ from adults. That is one difference, and potentially then more virus in the intestine in children. But also this group led by Lael Jonker in Boston on the top part of this slide have shown that in the cases of MIS-C, loss of tight junctions in the intestinal epithelium can lead to release of soluble S1 spike protein motif, which can then serve as a superantigen, triggering autoantibody production and non-specific T cell reactivity. And thinking of all of this together, I have in a perspective article that we published yesterday in Immunity, we have thought about whether there is a link here between the mild acute infection COVID-19 disease in children and the risk of developing MIS-C. And one such link might be, if we go to the next slide, that children, particularly growing children, would be less likely to mount a very strong systemic inflammatory response due to the fact that energy must be allocated for growth and other factors, which is different from adults. And this we know from, for example, infectious mononucleosis, where symptomatic disease in teenagers differs from asymptomatic infection in infants by stronger pro-inflammatory and systemic inflammatory responses, as well as bystander T cell activation. So with that in mind, mild acute COVID-19 would then perhaps be an effect of children holding back on some of their defenses, particularly these very expensive systemic inflammatory responses, leading to less bystander T cell activation, less efficient Th1 responses, and potentially then more persistent virus in the intestine. That in turn, with time, could then put them at greater risk of developing MIS-C. At least this is one potential hypothesis to try to explain these puzzling observations. And if we go to the next slide, when looking at the energy requirements of young children for growth, there is a correlation between the amount of energy required for growth of young children and the rate of asymptomatic infection, which decreases over time, as well as the incidence of MIS-C based on two different American studies. So all of this would then suggest that potentially this is an explanation for why children mount mostly mild COVID-19, which then would set them up for more persistent virus in the intestine, but in the end, higher risk of developing MIS-C. So next slide. I think that was it, yeah. So thank you very much. This is a hypothesis and a work in progress, but I'm happy to discuss further afterwards.
Thank you very much, Peter. Very interesting insight into the immunology. We will have time for questions after all the presentations. So I would like now to ask Elizabeth Tucker from UK to present herself and then talk to us about the clinical picture, management, outcomes, and if there are differences on MIS-C during all the waves with the different variants. Please, Liz, the floor is yours.
Good, thank you. Can you see my slides now?
Yes.
Perfect, great. So I'm Liz Whitaker. I'm a PEDS ID consultant at St Mary's Hospital in Paddington in London, and have been involved in trying to understand this really fascinating condition. I feel like I'm really going back to basics after that really thought-provoking presentation from Peter. So apologies that we're definitely going to have a less scientific little chat now, and I'll try and go through it. So basically, I'm going to run through a little bit that I'm sure is very familiar to everyone about the epidemiology and the presentation of these cases of pediatric inflammatory multisystem syndrome, also known as multisystem inflammatory syndrome in children. So we call it PIMS in the UK, but a MIS-C everywhere else. So I'll call it MIS-C for this talk. And some of the diagnostic advances that are exciting and coming through a little bit on treatment. And I had a sneak preview of Alfredo's slides, so I hope we don't have too much overlap. So if I go quickly, don't worry, better data coming from Alfredo and some of the complications as well, and what that means for other post-infectious complications. So this is directly from the CDC website, just showing what I think we've all learned, that this is a condition that predominantly affects children in middle age group. And so the median age is kind of 8 or 9 years, but it also affects adolescents. There does appear to be a male predominance, particularly in this US CDC cohort. In our setting, it's not quite such a big predominance of males in the UK. And this is just looking at what COVIDs look like for children in the UK. And what you can see on the left-hand side are cases in all age groups with the different waves. So this is going from April 2020 through to today. And these are admissions to hospital. So we see the first wave, the alpha wave last Christmas in January, a smaller delta wave, and then just what's happening with Omicron now in the UK, lots of admissions. But reassuringly, when you look at intensive care and then at deaths, although we see the first two big waves, and thankfully this is the amazing impact of vaccination for which we are extremely grateful. But over here on the bar chart is what I'm showing you is what's happened with the different variants for PIMS. And so we had our initial burst of activity in April, May 2020. And then last January, February, we had a big outbreak due to the alpha variant. And then not a great number of deltas in the immediate wave. So our delta outbreak was in June, July, but actually kept going over Christmas. And this, I think, is still all delta because our Omicron PIMS or MIS-C hasn't really happened yet. And I think we're going to hear as well about the potential benefit of vaccination in terms of protection from MIS-C. And I just put this in, this is also from the CDC website, showing how MIS-C tracks COVID-19 infections in children in the US. So remembering very different scales, don't panic, there aren't this many children with MIS-C, but in the blue, we can see MIS-C following on from cases. And I think we know that we weren't testing children well enough because they have such mild infection in the first instance, but testing has improved. But this proportionate alpha MIS-C response last Christmas as well that they saw. And then what I'm trying to show here with this delta thing is that although the cases of delta were almost as high as they were with alpha, the delta PIMS or MIS-C was lower. And the question is really whether this was related to a difference in the spike protein, whether this is a vaccine effect, and indeed what's going to happen next with Omicron in the US, where they've just had a massive spike of infections in their children and young people as well. So I think we don't know yet what impact Omicron will have from a MIS-C perspective, but talking to colleagues in South Africa, they haven't seen very high numbers. So I think we'll have to be cautiously optimistic about how many cases we're going to see in the next few weeks. In the UK, our peak of Omicron in children and young people was 4 weeks ago. So we are sitting here with bated breath and waiting to see what next week holds. And this is just an infographic from the CDC as well, just showing that they think that vaccination reduced MIS-C by 91% and that 95% of those who did have MIS-C in the autumn were unvaccinated. So again, just quite interesting, and I look forward to discussing this with you further later. So I don't really think I need to spend much time on the slide, which is describing the clinical picture of these young people who are very febrile and hot and red with abdominal and encephalopathic picture. About 40%, as we know, get shocked, and about 10 to 15% get dilatation of their coronary arteries, which I think is where the similarities with Kawasaki became particularly pertinent in 2020. And I think we're moving further away from it as we speak, with a very classic picture biochemically on the bloods. And I think we know what this looks like. The problem is it looks like lots of other things as well. These are just some of the mucocutaneous changes that we've seen in patients. Quite often the red eyes and PAM or solar involvement with the various different types of rashes on their skin, which can be urticarial in nature, but are usually macular-papular. And this is a slide from Mike Levine, so thanks to him for sharing, just showing that there is a massive spectrum of disease associated with SARS-CoV-2 infection, and thankfully predominantly very minimal symptomatic infection in children, a small proportion, particularly those who are adolescent with comorbidities, including obesity, get an adult type COVID-19 pneumonitis picture. There is a group of young people who get COVID pneumonia and inflammation. We haven't seen so many of those in our setting in the UK, but they are well described in the literature, and it does appear to be very much associated with older teenagers and obesity. And then there's various phenotypes of MIS-C. So there's the kind of fever and inflammation, antibody positive, not particularly unwell, maybe a little bit of shock. There's a very Kawasaki disease-like picture, which I think predominantly affects the younger children, but is a little bit more severe than typical Kawasaki, I think, and perhaps a bit more abdominal involvement than we would be used to, which is very interesting in the context of what Peter was just saying. And then finally, the group that we most dread seeing who have the worst outcomes, and these are children who come in extremely collapsed and unwell, and the ones who end up on ECMO. And this is the rarer end of the spectrum for MIS-C. I think we saw it more in the beginning when these children were presenting very late, and hopefully we see it a little bit less now that there's more awareness and they're coming to hospital sooner. But we do still occasionally have someone who comes through A&E looking extremely unwell and progressing very rapidly through all the treatments we have to give. But the diagnosis remains very challenging, because I can tell you the story that I tell in every presentation of the 11-year-old girl with fever and tummy pain and various symptoms, who's a bit hypertensive, who's got a clear epidemiological link with SARS-CoV-2 infection and a very typical biochemical picture. But depending on your findings, the differential could be anything from appendicitis to toxic shock to dengue to malignancy to typhoid to an autoimmune condition. And actually they all look quite similar when you're at this point in A&E or in the first 24 hours of the remission. So there's clearly an urgent need for better diagnostics, which the group here at Imperial have been looking forward to, led by Mike Levine, trying to make a host signature to look at this. And this is based on the premise that our immune response varies depending on what's triggering it, whether it's a viral infection or a bacterial infection, or indeed an inflammatory response, and that we can measure that host response and get a readout that we can then use as a diagnostic tool. And so we have this very generous grant from the Horizon project. And this very optimistic, this is Aubrey Cunnington's slide, to say that we might be able to reclassify infectious and inflammatory diseases based on how the host responds, rather than depending on finding the underlying pathogen. And we've had extraordinary recruitment to Diamonds across Europe, for which we're very grateful to everyone for taking part to try and understand this. This is a very busy slide, but it's just to show a really important getting phenotypic details, information about how the patient presented, as much microbiology as possible, in order to put them into different categories so that we can compare that immune response. So really important diagnostic pathway, and using a variety of techniques following RNA sequencing, including differential expression analysis and pathway analysis and signature identification, which I'm not going to go into detail in the interest of time. We have actually identified a 4-gene signature, which has really amazing performance in comparison with Kawasaki disease, viral infection, bacterial infection, toxic shock, and indeed all of them put together. So this looks really promising as a diagnostic test, and we are currently in the validation phase. And in fact, we would hope that this will also become a point of care test, which will make that question as to whether this is typhoid, dengue, or PIMS much easier in any setting, whether that's in our European setting or in an African setting. So it's very exciting. I know there will be a little bit more talk on the management, but the supportive care remains the mainstay of support for these children, as well as broad spectrum antibiotics, because there's often a broad differential and there's huge equipoise in terms of which immunomodulatory therapy we might use. We've led from Kawasaki treatments, and there have been a series of publications which have confirmed there may remain equipoise, including this one of the first 78 children in intensive care in the UK, showing that there's no difference in length of stay, if that's your measure of outcome, whether or not you get 1, 2, or 3 treatments. Hello? Sorry. Equally, there's this lovely paper, it's an observational paper looking back at children in France, which showed that even in the most severe cohort of children who ended up receiving 2 treatments, they got better quicker than receiving 1 treatment alone, which really started to make the case for steroids with or without IVIG, which we can discuss further, I'm sure. This American study also showed that IVIG plus steroids was better than IVIG. Again, retrospective observational data, but really big numbers of children, so quite useful. and very difficult to compare some of these cohorts because in France, every child, not in France, in America, every child is offered IVIG as first line. And then finally, the best available treatment study, or the BAT study, which is a multinational study from 32 countries with 600 children, where we compared IVIG to IVIG plus steroids to steroids alone, and showed that there was really no difference between those three arms. And that's hopefully demonstrated here, where you can see the time to improvement doesn't change, that when we look at the important biochemical markers that we follow, including CRP, troponin, and ferritin, there was no difference between the three groups. But I think importantly, although children will get better with no treatment, they do get better much more quickly if we treat them. And I don't think there are many people left who don't feel the need to treat these children anymore. But I think there's still lots of discussion about the best treatment. This is a really large international cohort, but it is limited by the fact that every setting is different, it's retrospective, and there were many challenges because people moved quickly through other treatments. And so we clearly need a randomized controlled trial and to try and look in different settings again. So the recovery trial has opened. Actually, I'll just say this, it is reassuring that all immunomodulatory therapy does seem to work regardless of what you have, which I think in settings where IVIG is difficult, you can still use steroids, which is good. So the recovery trial will hopefully be able to release the analysis of a comparison of IVIG and steroids quite soon. And my apologies that we don't have it ready for today, but hopefully just watch this space. And what's really exciting is that recovery has now opened in different sites, including Switzerland and South Africa. And so we are gaining that randomized data in other settings apart from in the UK. I think that we should have some really robust information on whether we should be using IVIG or steroids coming out. I might skip through these because I think I'm over time, but I think we know that encephalopathy is a feature in the most severely unwell of these children in about 20% and is associated with the worst outcomes. And I just want to bring this up for discussion because it is one of the things that persists at follow-up. This is a study from Great Ormond Street in London showing that a very small proportion of children have abnormal neurology at 6 months post-treatment. Whether this is related to the disease or the treatment they received, I think is unclear. And we will hopefully have data from this study looking at long-term neurological sequelae quite soon. But I just want to pose the question as to how related it might be to long COVID, because we don't understand what causes this phenomenon, which is another post-infectious phenomenon, and perhaps there may be more of a relationship than we know, so we urgently need to do more research. So in summary, this was a new spectrum of disease with a very wide spectrum of presentations, which I think we're quite good at recognizing, but still struggle a little bit to distinguish from other conditions. But there is a diagnostic optimism. Hopefully we will have a point of care test for you sooner rather than later. And the international collaboration on all of these studies has been really amazing. We're optimistic about Omicron, but still watching this space. Thank you for listening.
Thank you very much, Liz. Very informative presentation as always, and especially the last slides. So just to keep our time schedule, we will go on with the next presentation. It comes from France, François Angoulvant. He will talk about the risk of MIS-C according to the COVID-19 vaccination status of adolescents. And he will also give us an overview of MIS-C in France. Please, François, present yourself and the floor is yours.
Okay, hello everyone.
I'm sorry, Francois. I have to mention you are now present. You are showing your presenter view. Can you duplicate your screen? I can guide you.
Okay.
It's a second from top.
Yes. Okay, stop. Sorry, I will do it again. Is it good now?
Yes, it's fine.
Thank you very much. So I work as a professor of pediatrics in Robert Debré Hospital, Paris University in France. I will talk to you about the risk of MIS-C according to vaccination status And I would like to thank the organizer for their invitation. Here is my disclosure. So what happened during 2021 summer in France? There was a Delta COVID-19 wave, like many other European countries, but there was also a COVID-19 vaccination campaign in adolescents. So I will not talk long about previous study about vaccine effectiveness in adolescent, and we have now lots of evidence that COVID-19 vaccine prevent SARS-CoV-2 infection in adolescent, but little was known about MIS-C and the vaccination. So now, what about the COVID-19 vaccination campaign in adolescent? It started on June 15, and it concerned all adolescents from the age of 12 and above. All adolescents need to be vaccinated with 2 doses, and we used the mRNA vaccine, mainly Comirnaty. It was used for more than 95% of the vaccination. It requires agreement of one of the parents if the adolescent was younger than 16, and of course the agreement of the adolescent himself. And the vaccination was required to obtain a health pass, which is very useful if you want to have a social life in France. So the vaccination campaign went well, and at the end of October, more than 70% of the adolescents have received 2 doses. But the summer was also marked by the Delta variant. And the first data that we get from United States was upsetting because Delta variant seems to be involved in more pediatric admission. So we decided in France to increase our surveillance network, which is a huge collaboration involving National Health Agency, all the Pediatric Scientific Society, and also pre-existing research network. And in particular, PICURE, which is a research network of all the 41 French pediatric intensive care units. And together, it is around 400 pediatric intensive care beds. So here is the data collected by the National Health Agency about MIS-C. And as you see, every COVID-19 wave was followed by a MIS-C wave. It's just like the graphic showed by Liz Whitaker a few minutes ago. And here is the Delta wave, and it was followed, as usual, by a MIS-C wave. Here is the data from the PICURE network. So here is all the data about admission in PICURE related to COVID-19. So in September and October, most of the admission related to COVID-19 was due to MIS-C. So we decided to perform a study to estimate the risk of MIS-C by COVID-19 vaccination status. So we have included 107 cases of MIS-C in September and October, mostly in PICU. 33 were over 12 years, and among them, none were fully vaccinated. 7 only received 1 dose of vaccine, and 26 were not vaccinated. So to account for the increasing number of adolescents vaccinated over time, including the period in which MIS-C cases were measured, hazard ratio of unvaccinated versus vaccinated adolescents with at least 1 dose of vaccine was estimated using Cox proportional hazard model. So the result was 0.09, which means vaccine efficiency at 91%. And given the delay between vaccine injection and immune response, and between SARS-CoV-2 infection and MIS-C onset, we performed 3 sensitivity analyses in which adolescents were considered vaccinated after the first vaccine dose plus 14 days, plus 28 days, and plus 42 days. And as you can see, the results show similar trends. And 3 weeks later, there is a second publication, this time by the CDC. They perform a case control study of adolescents, and they have included 102 adolescents with MIS-C. And what they saw is the vaccine effectiveness to prevent MIS-C was 90%, which is very interesting because it shows the same magnitude of the French study. Now, still talking about MIS-C and vaccine, there was also some report from many countries of MIS-C after vaccination, linked maybe to the vaccination. So here is 2 preprints, so not yet peer-reviewed, one from the French team and the second one from the CDC. And it was a pharmacovigilance study. It was cases reported to the National Health Agency, and 9 cases were reported, which means around 1 case per million of dose injected. And here is the study from the CDC, and they have 21 cases reported, which means around 1 cases per million of persons receiving at least 1 vaccine. By comparison, MIS-C, post-SARS-CoV-2 MIS-C incidence is around 1 case every 4,000 SARS-CoV-2 infection, which means there is a much higher risk of MIS-C after infection rather than versus vaccination. So now let's go back to the situation in France. So more than 800 MIS-C cases were recorded, and same data that's shown by Elizabeth. Around half of the case concern children between 5 and 11 years. And we already know that there is some trial about it, that mRNA vaccine is effective to prevent SARS-CoV-2 infection, which means we can make the reasonable assumption that mRNA vaccine should prevent MIS-C in this age group, which is the most affected one. And now in France, what's happened? We have a new Delta wave that begins in November. And in December, there is also an Omicron, it's not a wave, it's a tsunami. Take a look at the number. The wave of Delta in France in December reached 50,000 daily cases, much more than the summer wave. And as expected, this wave of Delta variant was associated with the MIS-C wave. Here is data from the National Health Agency, which show an increasing number of MIS-C. And considering the length of this wave, we expect that it should last another 6 weeks. And again, we have a signal from the PQ, from the PQ network about an increasing number of cases in PQ. No signal about Omicron until now, and I believe it will be difficult to know what is due to the Delta and what is due to the Omicron in France. So the take-home message, mRNA vaccine seems effective to prevent MIS-C in adolescents, and so we can make the reasonable assumption that it should have the same effect in the 5 to 11-year-old group. There is a signal consistent but weak on post-vaccine MIS-C in adolescents, and maybe we should find another name than MIS-C. And I cannot give you any information about Omicron MIS-C, no answer yet. So thank you for your attention. I would like to thank my colleague from the Santé Publique France, the PICURE Network, and the COVID Consortium Pediatric Inflammation Group. Okay, thank you very much.
Thank you, Francois, for this great presentation. We are all very curious what will happen after the Omicron wave, indeed. We will keep up for the end of the session, so please, Alfredo Tagaro from Spain, could you present yourself, and then the floor is yours.
Yeah, thank you very much. Can you see the presentation correctly?
Yes, go ahead.
Okay, so thank you very much for inviting me to share the Spanish experience about MIS-C. I will talk a little bit about an overview, a bit about treatments for discharge, fever, and second-line therapies, and a slide about vaccination in adolescents with MIS-C. So the data that I'm going to show comes from a network named EPICO, composed by 90 hospitals in Spain, which is a sample of 10% of all centers in Spain. And in this network, we attended 1,600 patients in hospitals, and approximately half of them were hospitalized, which accounts for 12% of all the patients hospitalized in Spain, children up to 19 years, according to the national system statistics. And we also recorded 163 patients admitted in PICU, which accounts for 1/3 approximately of all children admitted in PICUs, and we're recording 9 deaths, which are 20% of the deaths recorded by the national system. So in this database, we have data from 186 children with MIS-C, clinical data essentially, and some microbiological data. Out of this data and from the data provided by the national system, we think that the incidence of MIS-C may be around 20 per 100,000 infected children, which accounts, which is a figure quite similar to what my colleague from France recently said, which is 1 out of 5,000, similar to one out of 4,000 that he mentioned. And if we estimate that we recorded approximately 30% of MIS-C, this means around roughly 550 cases in Spain. And this would mean that MIS-C happens in approximately 8 out of 100,000 of all children, all alive children, which it's a figure also is approximately similar to what in a recent paper published in Nature, Liz was a co-author mentioned, which is 1 out of 17,000 children. Here you can see the waves that we recorded. Please consider that there may be some fatigue in the recording by the researchers, but it looks like the number of MIS-C decreased a little bit depending on the wave. As you can see, the alpha wave is a little bit higher than the delta wave, but we also should consider that the vaccination in adolescents started in summer of the last year, so it may have also some impact. Our complications are very similar to what has been discussed previously. Mechanical ventilation 10%, death less than 2%, children that need PICU 54%, children with cardiological complications 54%, with 3% of aneurysms, and renal failure around 10%. 20% of them had features fulfill the criteria for Kawasaki disease, and around 20% had comorbidities. So it's very interesting what Peter said about the persistence of the antigen, because we analyzed all children with COVID, and the frame time and the time frame where MIS-C occurs, which is around 4 to 6 weeks, we found a positive PCR, a persistent positive PCR in 20 to 20% of all COVID patients, but in MIS-C patients, the figure goes to a very consistent 42%. I mean, consistent in time from the very beginning of the pandemic. So it looks like the PCR is more frequently found in children long-term, some weeks after the infection than in other children. So there is quite a lot of uncertainty about the treatments. There are some very relevant papers suggesting that the combination of IVIG is better than IVIG alone for hemodynamic outcomes. And this paper from Oldali that has been already discussed also suggests that the combination is also better than IVIG alone for fever. But as the WHO recently published and launched in the webpage this very nice meta-analysis, the certainty is very low for almost all of the endpoints. Only it's low, which is better than, of course, very low for hemodynamic support and for fever persisting today after initiation of treatments. In this sense, it looks like the combination is better than IVIG. However, most of the studies don't compare the combination versus steroids, or don't compare head-to-head steroids and IVIG. So we performed a study to analyze the treatments in the patients that we recorded, 150. 22% received IGIV and 22% received steroids, and 55% received a combination. And we tried and analyzed the probability of discharge in time and the probability of escalation of treatment in time, and also the fever 2 days after treatment initiation. For the two first endpoints, we did a time to event analysis, and for persistent fever, we did a multivariable weight logistic regression analysis. We analyzed 132 participants. We excluded 18 patients with biological agents, and we did a multi-state model with 3 transitions. And for each transition from treatment initiation to discharge, or to second-line treatment, or from second-line treatment to discharge, we analyzed the time to event probability and also weighted through a propensity score to balance baseline characteristics. So as you say in this figure, if we focus on probability of discharge in time, the IVIG performed better than the combination, and there was no differences between the combination and steroids. And for probability of escalation of the treatment in time, as is easy to understand, IVIG had a higher chance of needing second line than the combination. However, the steroids and combination were not different. In the head-to-head comparison, IVIG versus steroids, we found no differences in the probability of discharge in time. or in the probability of escalation of treatment in time. When we focused in persistent fever 2 days after treatment initiation, the steroids performed better than the combination, and the combination performed better than the IgIV alone. And in the head-to-head comparison, steroids performed better than IgIV. So, of course, this is a little bit puzzling because depending on the outcome, there's a different benefit. So the benefit of each drug varies a little bit depending on the outcome. For the time to discharge, IVIG seemed better than combination and steroids. For escalation of treatment, the combination was better than the other two. And for fever, the steroids performed better than the combination or IVIG. So for not hemodynamic endpoints, the combination had no major benefits, and steroids and IVIG performed quite similarly, except for fever where steroids were better. So I would like also to share a little bit of information about a small study that we performed in adolescents who had MIS-C with 48 participants from 8 centers. They were 12 years old or older, and we contacted them 10 weeks after immunization, after they have been vaccinated. We did a telephonic survey to test hesitancy and adverse events. So 42 of them responded, and 3/4 of them had been vaccinated, and only 24 had been unvaccinated. There were no difference in the MIS-C profile, and most of them received Pfizer, and most of them reported mild adverse events as fatigue, less than 24 hours long. So there were no severe adverse events, and in this set of patients, vaccination did not trigger MIS-C and was initially safe as far as we know. So I would like to thank all the network, the patients and the families, and I am happy to receive questions.
Hello, this is again here at the ECDC. Thank you so much, Alfredo. It was very interesting, especially the last study with the MIS-C adolescents, really filling in the gaps in our knowledge. So we don't see any questions in the chat. Please put any questions in the chat or raise your hand so we can give you the floor if you have any questions for our speakers. I would like to thank them again for presenting so interesting findings. In order to start the discussion in our second part of the webinar, we have a small activity. And Tanya, our admin assistant, will present it and let you know how you can do it. You can scan the code or go to slido.com and put in that code that you see on the screen. Tanya, please.
Hello, everyone. Indeed, I see, do you see my screen with a QR code?
Yes, we do.
So if you take your mobile phone or tablet and just, how you call it? I forgot this word, this magic word.
Scan
Scan it, exactly. Or if you go to the website and just type in slido.com and then use the code. So you will have it on your phone or on your computer. And then when you are ready, we can move to the first question. I will give you a few minutes for everyone to try to do it, because not everyone had a phone probably nearby. And so take your time. We can try to start with first question, and people can join on the way. Shall we do that?
Yeah, although I just see a question on the chat, and this is maybe for our, I suppose for all our speakers, because it's a little bit more clinical. Dr. Lovecchio, would you like to take the floor? But in the meantime,
Yes.
okay, yeah, please.
Hello, good afternoon, everyone. Sorry, I'm probably not able to switch on the camera, but no problem. What I was asking is, I don't know if you have any experience similar to what I just wrote. We are seeing a number of young infants or even neonates who has a sort of biochemical features of secondary HLH that is pretty similar to MIS-C. With elevation of ferritin, transaminase, D-dimers, and CRP inflammation markers, and low fibrinogen. Sometimes without fever, without abdominal pain, without myocardial involvement, and so on. So the first cases we met, we actually treated with steroids and with the classical protocols. But the last two, we had we tried to see and to try to understand what's going on without a specific treatment, and we realized that this kind of inflammation was going down spontaneously. So my question was, those patients fulfilled the criteria for MIS-C, but some of them, the youngest probably, had a sort of spontaneous resolution of this kind of inflammation. And the question was, do you think we really need to treat all these patients who develop inflammation after 10 to 14 days from infection, probably not fulfilling the classical timing of MIS-C? And do we need to build a more specific definition of MIS-C or PIMS in the next future, now that we have vaccination and most of patients with antibodies in the blood? So the real diagnosis will become much more difficult to be done.
So any of the speakers would like to take a try to answer? This is very interesting, actually. Yeah.
I mean, Peter here, I can just comment that I think probably all of us have seen patients with transiently elevated inflammatory markers that spontaneously resolve, either because they have not been diagnosed as MIS-C, they have maybe been misinterpreted as an appendicitis or some other infection. And then obviously it's possible that they are not picked up right away and then they spontaneously resolve. I've certainly come across a handful of such patients. They're usually not as severe as obviously the more clear-cut cases. And I'm sure Liz would have even more experience with this.
Oh, thanks, Peter. I was just trying to get my head around the question. Sorry. I think there are absolutely a group of children who've got undifferentiated inflammation, which is what you're describing, who just get better by themselves. And I think if they're not particularly unwell, and while you're going through the diagnostic process, if they stop being febrile and resolve, then there is no need to treat them. We have done echoes, cardiac echoes on those cohort at 6 weeks to make sure we haven't missed a dilatation, which we haven't seen. And so it feels like that might be a reasonable thing to do. I don't know, when you're talking about infants, I feel quite uncomfortable not treating an infant who's got evidence of systemic HLH because we don't know, that is a process that gets very hard to turn off the longer it goes on. And so I guess it really has to be decided on a case-by-case scenario. We've seen some young infants who've been extremely unwell, who've kind of acquired SARS-CoV-2 in the immediate peripartum period, and particularly a couple of preterms, and who absolutely needed treatment. But I don't know if that's exactly what you're asking. But and my concern, so with the BAT study, we showed that treatment does decrease the time to resolution. Like, all of these kids will just get better with time, but we don't know what the long-term consequences of that are. And I certainly think the persistent symptoms experienced from the cohort of young people we saw in April and May 2020 was worse than the persistent symptoms I see in children who were unwell this time last year. And I suspect that's because they had a delayed presentation and were inflamed for longer, which reasonably enough seems to have more persistent consequences. So I think there's a balance between turning off in 3 to 4 days seems fine, but going beyond 6 or 7 days feels quite uncomfortable because we don't know what the outcomes could be. I don't know if that answers your question.
Yes, thanks. Thanks to everybody.
Yes. Tanya, do you think we can go to the question?
Yes, let's try to do so. Can you see it? Which definition do you use for the multisystem inflammatory syndrome? And then you have 4 options to choose between.
And again, this is to start the discussion. Yeah.
So I see people stopped joining. So we have 29 participants. Agritza, I can keep the slide like that, and then you continue with your discussions. Probably someone will join later. And then let me know when I have to put another question.
Yes, yes. So, so the second part of our webinar is going to be, the discussion is going to be chaired by Delane, the chair, actually, yeah, the ESPID, please. And we have asked our colleagues from WHO to make a first intervention, kind of describing what the working group for MIS-C under WHO is doing, if possible. Karen Edwards, who is the coordinator, had another meeting, but she was trying to make it also for our meeting. But Marta?
I am here.
Okay, good.
To go back, so.
And Delane, oh yeah, Karen, yeah.
Yeah, thanks. I think that's an important point about case definitions that this you can see the variety of different case definitions that people are using: WHO, RCPCH, and CDC. So I think it's great having Marta from WHO just to sort of tell us a bit about the working group for MIS-C and moving towards a standard case definition, which would allow standardization of MIS-C across the globe. So thanks, Marta, for your update.
Or I'm here to help Marta as well, everyone. So hi, I hope you can hear me. My name's Karen Edmund. I work at WHO Geneva. I'm in the maternal and child health department. I'm a pediatrician, and yes, have been involved with MIS-C through the last year and a half. Just checking that my volume's okay. Do you let me know?
Yes, perfect.
Yeah, thanks very much. So yeah, so I think three big issues today, aren't there? So there's really the surveillance data, how the MIS-C cases are tracking in terms of severity. there's the issues around treatment, and then there's the issues around case definitions. So, so ready to try and help with all three. And really nice to see the data that's been presented. I sort of came in and out, but I think I got most of the information that was being presented, and very important to see the trends over time. So just initially some reflections. So trends over time, and I think we're all watching the South Africa data as well, and they were sort of ahead of the latest variant, the Omicron. So very important to really understand how MIS-C is panning out in South Africa, which was referred to. And also severity, which I suppose in general does seem to be decreasing, but I think we're all being very careful about that. Yeah, happy to take any questions about treatment as well, just before we jump into case definition. And it was nice to see again all the data, and just to let everyone know that for the treatment issues, as you've heard, so WHO has issued treatment guidelines for MIS-C, which do recommend the use of steroids as early as possible after for children who meet the case definition of MIS-C, and for children who meet the case definition of Kawasaki disease, that they should receive IVIG. And actually happy to present that meta-analysis if you're interested. And I think it's also ripe for updating. But maybe going to the sort of the question at hand, or the issue at hand around case definition. So I think, as you all can see on the slide, we have the three case definitions, and really in many ways they're very similar. And I think, and they're all fit for purpose, I think is really the bottom line. I think, as Liz outlined, one of the big issues with MIS-C is there's so much potential for misclassification, or so much overlap with other syndromes and other diseases like dengue and malaria in particular. So really the way so we're really at the refining stage. I think we've got good working case definitions which are being used across the globe, and really I think there can be improvements made, and which is definitely a good thing to do. At the WHO end, what we're doing is we have a big multi-country study which is just completed in 4 countries, which is in South Africa, Ethiopia, India, and Pakistan, where we have which is recruiting children who are admitted to hospital with any COVID positivity is the inclusion criteria, and then we're using that data set to really refine down into the syndromes, so severe COVID children, and then children meeting WHO case definition for MIS-C. That data set so that will have 5,000 children included in it, and that data set we are really just at the moment at cleaning and analyzing, and actually want to do exactly what you've got here on the slide. We actually want to see what the inclusion of additional features into the case definition will do to the sensitivity and specificity of the definition, and what the sort of inclusion and exclusion of important inflammatory markers will do to that case definition. But when we don't have that data available yet to show you, it will be available in about a month. And I think just one final point to make is, I think Liz's point also about new diagnostics is very important because of this problem with misclassification. And if we can have a better diagnostic tests, I think we'll all be in a better place. So I wanted to stop now, but Marta, are you on the line? Would you like to add or to take this away? your own
Well, you have made
style.
an incredible summary. I just wanted to, just in case there is like some questions about like what we were saying. Okay, so can you see my screen?
Yes, we can. Thank you.
Yes.
So just to, I know that we are quite in a rush, so I don't want to take much time, but just to make like as we are talking on different definitions. So the three current case definitions that are more or less used is about like the WHO, the CDC, and the UK one, and you can find them explained more in detail in the clinical guidance, the living clinical guidance from WHO that is published in the website. The treatment for MIS in children is included within the recommendations of severe and critical condition of COVID. And the summary that you will find in the guidelines, this comes from a complete meta-analysis of 3 studies that included around 885 children. Those were 3 big studies, one from US, another one from France, and another one is a global. And we need to also take in consideration that we need to have more evidence. We are all waiting for more publications with more studies and more evidence to come out, and probably this recommendation is going to be changed or upgraded. So right now it's based mainly in for well-informed parents or of children or family. Despite the uncertainty that we have right now, they would choose to give some medication to their children. No? So it ends up being like a conditional recommendation because it's still not, we still need more data, we still more patients. So it talks about like the conditional recommendation of use corticosteroids in addition to supportive care. These corticosteroids can be given orally or IV for children that are between 0 and 18 years old, and also meeting the case definition for MIS-C and also the recommendation for MIS-C and diagnostic criteria for Kawasaki. So you can go to the website that we have. We are still working, as Karen was saying, like trying to get all the group together as more evidence is coming out, and we are expecting to be able to make some modifications or analysis as more data is coming out. But right now you can also access to our current guidelines, not only for MIS, but also for all COVID presentations, where right now, currently, the last recommendations have been coming for adults for JAK inhibitors and sotrovimab, but many other things are about to come out in the next weeks. And happy to answer any question that comes from our recommendation guidelines. So thank you.
Yeah, thank you both for that update from WHO, and both in terms of standard diagnostic criteria as well as the treatment recommendations. I'm not sure if there's any questions from the audience. I think there's a bit of chat going on about disease severity, Omicron and different variants and disease severity, and whether we will see any difference in Omicron compared to other variants. I'm not sure whether any of the previous speakers can maybe give a comment on disease severity specifically.
Hi, this is Alfredo. Well, as Liz has written, the Omicron MIS-C haven't arrived yet, although the Omicron hit quite strong in the last 2 weeks of December in Spain, so we would expect to start seeing some cases in the last week and this week, and from now to the next 2 weeks, and hasn't happened yet. So, well, we will see, but we don't have enough information yet to answer that.
Yeah, and again, in South Africa, it does seem to have been, say, less severe, less cases of MIS-C, maybe a younger age predominance. But so I think, South Africa data is helpful, but most is not published yet. Over.
Thank you. And I suppose the other question is whether it's earlier recognition and treatment, and maybe things, maybe slightly different from where we were a year ago, whether that has influenced any of sort of disease severity.
Delane, I think it's even a year ago, if we look back on the cohort of young people that we had in London this time last year when we had a massive peak, and we're kind of seeing huge numbers every day, but for a relatively short period of time, the number of ventilated children was much less than it had been prior to that, and lower, I think, than your estimates, Alfredo, and probably less than 10% had significant renal hits as well. But I would attribute that to early recognition, because I think we did a campaign of education we kind of let all our local hospitals know to think about it. Now, there may be the possibility we over-treated a few children out of enthusiasm to avoid severe disease, but I don't know where the balance lies in benefit and risk there. And similarly with Delta, we all felt, and maybe I speak on behalf of other people inappropriately, it didn't feel like we had as many severe MIS-C or PIMS cases after the Delta peak we saw in the UK in June, July. Although cumulatively, because there was ongoing transmission for a longer period, we have seen as many cases, but I don't think there was any change in severity. So I think we can just be optimistic about Omicron. It's really nice to have such sharing colleagues in South Africa who are regularly updating us on their experience, but hopefully the data will stand up to that, as Karen says.
Thanks, Liz. I think there's another question. Given the high number of hospitalizations in children during the current Omicron wave, are children admitted with or due to SARS-CoV-2?
Yeah, it's both. It's both. When you look at the data from PQ, there is some incidental COVID diagnosis and also some children admitted for COVID. And in the hospital right now, in a pediatric ward or a surgery ward, it's about half of the children admitted with an incidental SARS-CoV-2 diagnosis. But whatever, given the tsunami of cases, the number of children admitted is increasing. And but most of the patients experience only mild cases, and most of them, it's on specific children. It's children with chronic condition. It's infant under 3 months of age. And in France, because of the Delta variant, we still have a lot of MIS-C. Thank you. Over.
Yeah, thanks, Francois. I think, our experience has been similar at my hospital. Liz, I think you had your hand up.
I know, I was really curious because I think, Francois, you're saying you have both Delta and Omicron at the moment in France. You're in a quite unique opportunity to do a direct comparison on your own ward. And I would be curious, are you doing genotyping on all the patients, and do you see a difference? Because I think we've looked at this data with NHS England here, and it really looks like, as the South Africans described, we have definitely seen a different spectrum of disease with Omicron, and certainly PICU admissions are went down rather than up during Omicron as Delta phased out, which is really extraordinary, and very grateful. And I guess we don't know how much of that is vaccination, how much of that is the fact that like 70% of kids in the UK have had COVID. So there's a bit of chat in the chat, and Peter was talking about protection from prior coronavirus infection, but protection from prior COVID infection, I think, is something else that we kind of don't really understand, both for severe disease and MIS-C in children. But I'm really curious, because it's a very unique position you're in, I think.
Yes, but unfortunately, the lab is so much overwhelmed that I'm not sure we will have the data. And right now, I don't have very robust data. I have a feeling that we see a lot more of, for example, sickle cell disease, sickle cell patients. Okay, right now with the Omicron wave that we saw with the previous wave with the other variants, probably because they are more febrile and maybe it causes more acute sickle cell crisis. And so yes, I hope to get back to you in few weeks, probably few months, with robust data. Anyway, I hope at this time Omicron will just be history, but okay, we try to do it.
I would like to add that some of the children that went to the PICU with COVID had a co-infection with RSV or metapneumovirus. So it's difficult to say which of them is responsible. And although we believe that very likely RSV or metapneumovirus are more responsible for the disease in these small children with bronchiolitis.
Yeah. Thanks everyone. Liz, you were going to.
Yeah, I was going to just jump back in because just on the hospitalizations and things, the other data that I've seen is in the UK is there's no excess hospitalization. So the number of children who are admitted in hospital, so although there is a larger proportion who have positive PCRs, there isn't more than expected admissions. In fact, if anything, and I'm going to really curse myself when I'm on call next week, our admissions in the UK, both in intensive care and on the wards, are lower than they have been in October, November, December of this year, despite the fact that there is an increase of hospitalization of children infected with Omicron. And so I really think it is reflecting community prevalence, if that makes any sense.
Yes, we saw exactly the same thing in France. And despite
did you say there is an excess?
There isn't an excess.
Oh,
no, so in fact, there's fewer admissions overall in hospitals than we would expect for this time of year, despite the Omicron. Sorry, Francois. Yeah.
Yeah, no, yes, I fully agree. There is a lot of children admitted with or due to SARS-CoV-2 infection, but the other virus almost disappear, and the RSV epidemic is now over in France. And to be very clear, it's like that we told to the health authority in France, is RSV send much more children in hospital than SARS-CoV-2, even the big Omicron wave. So I fully agree with Liz. We share the same experience.
Karen, I think you had your hand up or wanted to ask a question.
Oh, it was just my connection. I just missed that, and maybe just in case others did. So fewer admissions for other.
So there is. Oh, I think her connection's really not working.
Yeah, I think she keeps on cutting out. Okay. Maybe we'll wait for her to get back and ask a question again.
I was just going to comment on the sickle patients actually, but while we're waiting for Karen to come back. So, because we have quite a big sickle cohort in Northwest London where I work, and we have seen a number of our cohort coming in with painful crises or chest syndrome, but they haven't had COVID, pneumonia, and that kind of inflammation in the same way. Just to clarify that, but it does, like any other infection, it can trigger the usual complications of sickle, which I think is what you were saying as well, Francois.
Yes, but it's not very clear because it just one case report. But 2 weeks ago, we had an adolescent with a SARS-CoV-2 infection. I believe it's Omicron, and we make a TDM, okay, tomodensitometry, and there was an concern. There was a pneumonia, but no glass ground lesion. Okay, and we said, okay, we treat it like acute chest syndrome, like usual. But now she's intubated and ventilated. So I don't know how much this infection with Omicron is just a cause for a decompensation for acute crisis, or maybe it could be had a specific severity for this patient. I don't know yet.
Can I ask, just sorry, might derail the MIS-C chat, but in terms of access to therapeutics for that cohort, and this is probably relevant for others as well, in terms of, what treatment options there are, very briefly, do you get any access to monoclonals? Maybe this is probably something we should take offline. I'm just curious if anybody else is managing to get hold of the monoclonals for children and young people, but maybe I am talking out of line because it's meant to be about MIS-C. Sorry.
Yeah, I mean, since you've asked that, maybe just within sort of the European sort of region, what access do people have to monoclonals? Is an important question. I think we have limited access in the UK, but I'm not sure what's happening in France, Spain, Italy, some of the other countries in Europe. Whether Francois may have thoughts.
Yes, we have access to monoclonal, but with Omicron right now, do you mean the last monoclonal against Omicron?
Atrovimab, yeah. So that's we struggle to get access to that in sick patients, but we can use it in the community. And I just wonder, and we don't have any access for under 12s, which is problematic as well.
Yes, I believe it's difficult. We should access around now. I don't know if we already had it or just expected it. Not sure.
Okay, thanks. There's a few questions on the chat. I think one of them from Simon Drysdale, thinking about steroid dosing and disease severity, and whether there's any data on milder cases being treated with lower doses of steroids. I know we're sort of doing that in some of our sort of patients that are being managed at smaller hospitals, but I'm not sure whether there's any data on steroid dosing and use in different disease severities.
It's a difficult question, as if you look at the great presentation from Alfredo, you see whether you need to give steroid and immunoglobulin is not very, is an uncertain matter. And to know if we have to give usual dose or high bolus. Right now, I said there is no evidence for bolus rather than usual doses.
Okay, Alfredo, Liz, any thoughts?
No, I mean, yeah, we would just follow the standard guidelines. Probably we will start with 2 milligrams per kilo of methylprednisolone, but also depending on the severity of the patients, of course, we can go with higher boluses, as Marta showed in the guidelines. So 10 to 13, but usually we start with 2 milligrams per kilo.
I think Alistair has his hand up.
Okay, yeah, I didn't see that. Alistair, do you want to ask your question? I think you've posted something in the chat, but maybe yeah, if you want to ask that.
Just a quick comment. Yeah, we're already sort of modifying our practice here at GOSH based on the evidence that steroids are effective in isolation, and so for milder phenotype that aren't shocked, we're going with the 2 per kilo dose just as standard practice now, really. And if they're shocked, going with higher doses, but obviously that's not evidence based. But in our anecdotal reports, that seems to be working as a strategy so far. But watch this space. But yeah, my two questions were about to the WHO representatives. Are you working with the CDC as well, so that we have a unified diagnosis across all organizations, a unified criteria and terminology? And secondly, I'm a bit obsessed with this, but can we update the name, because they're both terrible and they both don't clearly state a link with SARS-CoV-2 infection, and I think we've got enough evidence to show that they are linked now, and we could reference that within the name of the condition.
I missed the second bit. Sorry, Alistair. Could you just repeat your second question?
So it's about the name. I think we're at a stage now where we could update it. They're very clumsy names that were created in the beginning of the pandemic when we weren't certain of a link between SARS-CoV-2 and the condition. I think we should update the name to acknowledge that there's a clear link between SARS-CoV-2 and this condition.
Point taken, thank you. And yes, we are working very closely with CDC colleagues around these case definitions, and CDC are actually in the middle or very close to revising their case definition, which will become much closer to the WHO case definition. I think that's really going to be available imminently because it was really 2 months ago they were the last communications we had. So I think that's coming very soon. Thank you.
Okay, thank you. There's quite a few discussions in the chat of sort of steroid dosing and various questions regarding that. But are there any specific questions that the audience have to the speakers and our WHO representatives with regards to some of the issues that we've raised earlier?
Yeah, and probably while we're waiting for that delay, and I was just also going to mention in the WHO guidelines, we weren't able to issue a guideline on dose of steroids or IVIG because there were only 3 studies that were able to be included in the meta-analysis that had a comparator group available for inclusion, and the doses used in the studies were very, the standard doses that we've just heard described at the meeting, the 2 milligrams per kilogram. So that was the current state of the evidence when the guidelines were done end of last year. But more data from you all would be most appreciated, data with comparator arms so we can compare.
Thanks, Karen. I think we keep on losing you. I think, Francois, you have your hand up.
Yes. So in France, we make a study about suspected post MIS-C vaccine. I'd like to know if other countries perform such a study. And what did you do as a usual test? Did you test serology antibody with anti-N and anti-S? I would like to know if we were alone to see that, us and the USA, and what you think about, including revising the name.
Any comment from the speakers, Liz?
I'm sorry because I was distracted reading the chat actually. I think that it's really tricky, isn't it, until we have better diagnostics in some ways. Alfredo's laughing at me. Go on, Alfredo, you have something to say. Help me out here.
No. I was saying that. Well, we all wonder questions like that, but I think we still need more strong evidence to change things. I sometimes wonder about including neurological disease in the definition, because you have shown that the neurology features are also quite prominent sometimes, which I believe they are part of the shock, and sometimes you wonder if it is something that we should add, and of course with the vaccination, the serology is going to be no longer as useful as used to be, but for the moment, I don't think if there is like very good suggestions for changing. I think this is a good time to discuss if you would change something of the definition.
I know the neurology is tricky though, isn't it? Because it's a proportion, it's the sickest. I mean, whether it could be used as an indication for treatment, but the problem is that it opens up a broader differential quite a lot of the time, because when they're very encephalopathic, we then worry about other things like herpes simplex, etc., and or maybe even a neuro malignancy or something. And so we kind of want, you're not so keen to jump in with high doses of steroids. And so it is quite tricky because it is just such a non-specific condition. That's why the definition has always been challenging to narrow down. But yeah, I agree. When 20% of the patients have abnormal neurology, it is worth mentioning, isn't it? I think it's also about phenotyping. So the other problem with the definition is it assumes that all of the children who present with this condition are the same, when actually, and we probably ought to use BATS for this, we should be defining different phenotypes. So there is the Kawasaki type presentation, there is the cardiogenic shock and neurological presentation, and maybe we actually need more than one case definition, and maybe that would make it simpler to have a useful case definition for people in A&E if we were to do different phenotypes. But it's simpler and more complicated, but I don't know. I think that's a never-ending discussion.
Okay, thanks everyone for those comments. Yeah, I think we've there's a lot of good things coming up in the chat, but in terms of whether there's any questions to the speakers that anyone has, but to try and sort of bring this to a conclusion, just thinking about sort of we have a lot of information that's come through on MIS-C, and also we need a better case definition, and maybe, as Alistair suggested, a better name for this condition. But just thinking about more broadly how we move this forward in terms of the collaboration. I mean, this webinar was set up jointly with ECDC and ESPID, and this is the second of two webinars. I think we had a long COVID one last year, and just thinking about the value of such a collaboration and how we move this forward, and maybe the situation for MIS-C is slightly different from long COVID, and just thinking in the future whether this is something we want to continue doing. We could do it under the auspices of ESPID if that's something that would be of value. I know the ECDC have been sort of looking at what's going on both within the European region, but also internationally. So I think this will be an important point of discussion as to how we take this forward, and my ECDC colleagues may also have their views and thoughts, but I'd like to just open it out to the ESPID audience, just thinking how we take this forward.
Yes, please. Yeah.
Yes.
Sorry.
I would like to concur that it would be nice to hear from the speakers and all the participants. We actually have one more, rather two more slides. One of them talks about if you would like more webinars, but particularly since the speakers are exactly in that particular subject, do you think that there is some need for a concerted action from our side? And that's okay. So Tanya put up the first slide that we said. Do you think that we need one universal definition? There was some discussion about that. But yeah, we would love to hear your views about this type of activities, and if they should be continued, and particularly for MIS-C, if you would like us to do something more. Thank you.
Any thoughts from the the speakers just in terms of how we take this forward and collaborate in the future, because I think there's a lot of importance in us talking to each other and collating whatever information we're getting.
Well, I think that what we are all of us wondering is about how it's going to be the MIS-C wave after Omicron. So I don't know if ECDC will have data available from the national health systems and may gather them and share with ESPID or with pediatricians from all of Europe. That could be something interesting to get these data and to put them together and to share them. But I don't know if ECDC has the network or the capacity to put together those data.
So as you know, we have the European surveillance system, and the focal points in the member states report to us a whole set of fields on COVID, which includes MIS-C. The problem is that the countries, particularly our focal points in the public health, do not really collect this type of data. So we have very, very few numbers. I think it's a highly specialized area where probably pediatrics is the specialty that gets or is in position to collect this type of data. And also, public health institutes do not have that. Yeah, sorry. Yeah.
So, sorry, and I don't know if you have also any links with the European Agency of European Drugs Agency, or the EMEA. But I know that they have some studies ongoing of adverse events after vaccines, and it would be also very helpful to know before they are published, because one of the things that we learned in these pandemics is that to wait for the papers to be published sometimes is too long. But if there are some data, then they can share about the adverse events after vaccination. That would be also very helpful. But I don't know if you have these links to the EMEA, so we can get some of these data.
Yes, this is we do have regular contacts and a lot of back and forth with EMA, particularly on vaccinations. We also coordinate a meeting between the national committees on immunization, where they are also briefed by EMA on regular times. And if you think that we could organize, for example, another webinar where we can call them and ask them to present this type of data focused on pediatric patients, if that's interesting to all of you, yeah, we can do that.
Thanks. Yeah, I think, Francois, you had a question?
Yes, I have two remarks. I hope that CDC will adopt a definition much more closer from the WHO, because I think the WHO definition was a great achievement, and thank you very much for those who built it. It was very, very good, and I think it's much better than the CDC one. This is first remark. Second remark is about to answer this pandemic, and what we see in every country. It was the case in UK, it was the case in Spain, it was the case in France, that we can perform quickly some study because it was from a pre-existing research network. And I think if we want to do this on a European level, that we have to have a functional pre-existing research network now. And not to wait the next crisis.
Yeah, no, that's an important point, Francois, and I think we need to sort of develop those research networks, across Europe. I think that'll be really, really important. Any other questions? I know there's a lot in the chat about linking up with the CDC, and I'm not sure whether that's something that the ECDC or WHO are doing, just with regards to sort of both the case definition, but also collaborative work. I mean, we do have contacts in the Paediatric Infectious Diseases Society in the US, but formally have not made any sort of links with CDC.
Maybe some experts from ESPID may help to launch some recommendations relating to COVID-19 in children that are also supported by ECDC. And this is something that could make stronger this link.
And it's Karen again. I'm not sure if my audio is any better. Can you just let me know?
Yeah, we can hear you. We can hear you clearly.
But for now, okay. And I wasn't sure if my earlier comment was heard, because CDC are in the middle of looking at their their data and their case definition. So we will have more information on the new CDC case definition very soon. And we at WHO are definitely analysing our case definition, and as I said earlier, we'll have 5,000 children that will contribute to that analysis. So as soon as that's done, we'll be able to feed back to yourselves and also to CDC and other colleagues as well. Thank you.
Okay, I think comment from Liz in the chat about any value in a Delphi process. Do you mean in case definition or treatment?
For case definition, no. I think for case definition, I think treatment needs to be based on the evidence that we have. I mean, maybe we should argue that a case definition should be based on the evidence as well. And we have done some analysis of presenting features, but I think this comes back to the phenotyping. I think we have to stop calling it all the same thing, because that's, I think, where the hindrance and where the case definition loses value.
Yeah, and I think we need a big data set. Yeah, we need a big data set to basically, do those diagnostic accuracy analyses, sensitivity and specificity, including an area, particularly the inflammatory markers. So really to help refine these. I think we're getting closer as an overall definition. I completely agree that phenotypes within that would be very helpful too. And also, as we said before, the diagnostic markers too. But yes, we'll have some more information soon that could then be used for a Delphi process, for example, in terms of the data.
Yeah, I think there's a question from Alistair. Will there be an open consultation on the updated definitions and terminology?
Yes. Yes. And again, but data driven. So let's wait for the analysis first, is our approach anyway. And just really feeding back to you all about what our current process is. Over.
Okay, I think there's another question in the chat. Is it possible to contribute to MIS-C data collection, WHO, BATS, recovery, with a couple of cases? I'm not sure what Andrea means with regards to a couple of cases.
I'm trying to recruit him to BATS. I've put the link in the chat.
Oh, okay.
Yes, and I'm not so good with my online techniques, but at WHO, there's two ways of contributing, or really one main way. We have what we call the clinical data platform, And and maybe Marta, you might be able to do that easily. Just put that link in for that. So that's one data source that we use at WHO, and then the other data source we're using is this big multi-country study that I mentioned. So yes, please.
Okay. Any other questions, thoughts that people have about how to move forwards? Whether these webinars are of value and how we can continue to collaborate, which I think everyone's suggesting that we need to do that, but how best we go about that and moving forwards. Any last thoughts, comments? ECDC colleagues, please chip in as well with any things you may feel are important for ECDC to be achieving.
Yeah, and also just to also mention that we at WHO we do have a MIS-C working group which we are convening on an as needed basis, and we have opened its membership a couple of months ago. So very happy to hear from colleagues who would like to be part of the MIS-C working group. But as colleagues on the line who are part of the working group know, it is being convened on an as needs basis, basically due to workload issues. So, but we would be very happy to hear from other people who would like to be part of that too, and just adding back into the issue around the open consultative process around case definitions. Yes, we are very happy to disseminate that information more widely to people on the call now, and also through our ECDC colleagues too. But Marta, you might like to add as well.
Tanya, would you like to put the last slide up? Okay, and of course the discussion can go on. Sorry. Okay. Okay, maybe, okay, it doesn't matter. We will have a short discussion with Delane and ESPID and among ourselves about possible other webinars. We have already an idea that Alfredo mentioned. We'll work on it, and we'll keep our eye on what is going on in the working group under WHO, and of course anything else, particularly what comes after Omicron. I would like to thank everyone again for attending. Delane?
Yeah, no, thanks everyone, for the speakers, for the audience, for being so engaged and giving us the latest information. I think it's really valuable for us to continue to have this sort of dialogue and collaboration. And obviously things are changing by the day with new variants, and we've yet to see what's going to happen with Omicron with regards to MIS-C. So I think this was really an important webinar to have, just to get a view of what's going across different parts of Europe, but also the WHO and where things are heading. But I think this dialogue is really important for us to continue to have. So I'm sure we will all reconvene at a later point, because I think this is an important topic we do need to be focusing on.
Yes, I would like to thank also our technical support, Hakan and Adam, and everyone here at the ECDC who helped, and my colleague here, Katerina Mugu, who also helped with the presentation. Thank you so much, everyone. Thank you again to the speakers, and we'll be in touch soon. Thank you. Bye.
Thanks. Bye, everyone.
Bye.
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 Thank you. Bye.